Hello, everyone. I am Vanessa Cartagena, Meetings and Events Associate here at America's Essential Hospitals. Thank you for joining us today and welcome to today's webinar, part of our COVID-19 webinar series, The Seattle Experience Insights for New COVID-19 Challenges. Before we start, I want to recommend you use the dial-in number displayed on your screen to listen to today's presentation. Because COVID-19 is causing high internet usage, you might experience interruptions if you try to stream the audio portion of this webinar on your computer. So to ensure a trouble-free experience, we recommend you use the dial-in number for audio as you watch the presentation on your device. Also, like many of you, all of us here are working remotely, so please bear with us as we adjust to the challenges of producing a webinar from multiple locations. I wanted to take a moment to point out the webinar section of our website at essentialhospitals.org. You'll find upcoming and recorded webinars under the Education tab of our website. Once there, look for the webinars link in the menu just under the photo. As a member, you have full access to the rich library of recorded webinars on our site. Today's webinar is being recorded and will be available on our website by the end of the week. Today's slide deck is also available for download on our webinar page. To ensure you can interact with us today, please make sure you have selected both the participant and chat tabs on the right-hand side of your screen. Although your line is currently muted, we can open it if you have a question for our presenters during the Q&A portion of today's call. If you want to ask a question, please use the Raise Your Hand feature at the bottom of your participant panel. We will unmute your line and announce you by name. You may also chat in your questions in the chat box at any time during the webinar. Now, I'm very pleased to introduce today's lineup of speakers. They include a member of our staff here at America's Essential Hospitals, Jennifer Stevens, Principal Researcher. Joining her today is our guest speaker, John Lynch, Medical Director of Infectious Diseases Clinic and Associate Professor of Medicine and Allergy and Infectious Diseases at UW Harborview Medical Center. Now I will turn the call over to Jennifer, who will kick off our presentation today.
Thank you, Vanessa. Next slide, please. I'd like to start today by sharing a gem from a family member that's helped me in difficult times. Cry when you need to, rejoice when you want to, and love as much as you can. Thank you for expressing love through your commitment to your patients, to your communities, and to all of the staff at Essential Hospitals. Next slide, please. America's Essential Hospitals is trying to express our love by focusing on our vision, being an effective voice and providing equity and excellence in health and healthcare. To do that, we are now, more than ever, working to support securing funding, sharing best practices, and facilitating member-to-member knowledge transfer. Next slide, please. Some of the resources that you are getting and are seeing from us you're familiar with, including our federal and state newsline articles, our latest from Action, and our action alerts to spur legislative activity. In addition, there are new COVID-19 channels of communication that you've probably been seeing from us. Our COVID-19 updates that come out weekly include policy updates, new resources, as well as information on members in the news and upcoming webinars and calls. In addition, we host this COVID-19 webinar series that's available to you live or on demand on our website. We hope you'll join us next week as we talk about fundraising for nonprofits and foundations in the COVID era. We also have an email list. Next slide. Use the links embedded within this web page to sign up for our email list or access our webinars. To join the email list, click the link below, sign up with just your name and email address, and then you can begin exchanging practical and timely information with fellow member hospitals, as well as our staff. Next. We also encourage you to go to essentialhospitals.org to access our resource page. In the middle of our home page, you'll see this red bar. Once you click on the red bar, next, you'll be taken to this page with a plethora of resources from federal, state, local, member, and nonprofits. Here you'll find resources including tools and policies, workflows and plans, and we also encourage you to submit resources that you would like fellow member hospitals to be able to access. Next. Today I will review a COVID-19 timeline. I will then be honored to pass it over to our guest speaker, Dr. Lynch, to talk about lessons learned from Harborview Medical Center. And we hope that we'll be able to engage in a robust discussion at the end of the webinar today. Next. We think it's important to review the timeline so that we can remind ourselves what's happened in just a short 6 months as we think about what comes next and how to plan for the future and potential other pandemics and endemics. Next. It is hard to believe that it's only been 6 months since COVID-19, the SARS-CoV-2 virus, has been in our human lives. Going back to December 1st, that was the earliest date of recorded symptom onset in the Hubei province in China. And it was only at the end of December that Chinese authorities alerted the World Health Organization. Next. In January, things start to pick up in the U.S. The CDC starts implementing health screenings from travelers from Wuhan, the major city in the Hubei province in China. They start at just 3 hospitals and then 10 days later expand it to 20 airports. In addition, the United States sees its first case in Washington State on January 21st. By the end of the month, we have 7 COVID cases in the U.S., including the first person-to-person transmission of the virus. Next. In February, things become a bit more serious. We see things picking up in our cities, but as well as our states. San Francisco declares a state of emergency on the 25th, and just 4 days later, Washington State declares a state of emergency. We also have our first reports of a U.S. death related to COVID-19, and the FDA issuing emergency use authorization for a CDC diagnostic test. Our member hospitals are playing important roles here as they are treating patients coming off of the Diamond Princess, as well as other travelers and those who are catching the virus from community transmission. It is also during this month, on February 26th, that the White House creates the COVID-19 task force. We end the month with 24 COVID cases. Next. In March, the early part begets a sense of urgency. We see the $8.3 billion in the Coronavirus Preparedness and Response Supplemental Appropriations Act. That includes a waiver to remove telehealth restrictions. It provides HHS funding for testing, therapies, and vaccine development, and also funding for small businesses. You're seeing states taking action. 23 states by March 10th had declared a state of emergency. In 16 states, schools had been closed. And by the time we hit mid-March, all states have reported cases, with West Virginia being the last state to report any positive cases. We're also seeing social distancing take hold at this time. And while social distancing is being proposed, we also see large groups eschewing social distancing and gathering for events like spring break. It's also in the early part of this month that the president declares a national emergency, which frees up, in addition to the $8.3 billion under the Preparedness Act, an additional $50 billion for response. Next. In late March, we see additional funding come out. The Families First Coronavirus Response Act is signed into law on the 18th, which addresses food insecurity, paid sick leave, free COVID testing, and expands unemployment. On the 27th, we see a very large Coronavirus Aid, Relief, and Economic Securities Act, or CARES, pass on the 27th at a value of $2 trillion. There's a lot that goes into the CARES Act, and one of the benefits for working for America's Essential Hospitals is that we have our policy and legislative experts to tell me the details of what's included in that act. They did a webinar in April where you can access on demand to get details on what's included in that act. During this time in March, we're also seeing some new milestones. We're hitting 50,000 cases, 1,000 deaths, and 1 million Americans tested at this time. By the time we get to the end of March, 42 states have a shelter-in-place or stay-at-home orders, and over 186,000 COVID cases. Next. In April, tensions begin to rise as unemployment reaches 10 million, and by the time we get to the 15th, claims reach 22 million and continue to rise. We also have some confusing changes to the public with recommendations in treatment and prevention around hydroxychloroquine and the public use of masks. New milestones that we're reaching in April, including the death toll passing 10,000 and starting to see some local reports of disproportionate infection and death rates among Blacks, Latinos, and other minorities. It's at this time that we see tensions rise as Easter comes about and folks are starting to feel isolated and want to gather in person, and anti-lockdown protests begin in Michigan mid-month. Next. Just as we talked about the Easter gatherings, there other gatherings in late April, including the Blue Angels and Thunderbirds flyovers, begin to draw crowds, and folks are beginning to gather in areas refuting social distancing. In late April, hospitals do begin reopening their services to provide medically necessary surgeries and procedures, and we start to see more than 1 million cases in the US by the time we get to the end of the month, as well as 18 states reported more than 10,000 cases each. On April 24th, you're also seeing the fourth legislative action, the Paycheck Protection Program and Healthcare Enhancement Act. As part of this act, additional funding is provided to support hospitals and providers for COVID expenses and lost revenues. Next. In May, additional Blue Angels and Thunderbird flyovers draw crowds, and state stay-at-home orders and shelter-in-place orders have begun lifting restrictions. So all states with those orders in place have lifted the restrictions in some way, essentially entering phase 1 of reopening. Cases are starting to decline or remain stable, and we hit Memorial Day, and we also start to see gatherings nationwide in protests in opposition to the death of George Floyd, drawing crowds. We end May with more than 1.7 million COVID cases. Next. It's only the 3rd of June, but we've already had some action to note that we have exceeded 1.8 million US cases and 105,000 deaths from COVID, and we are seeing continued protests that draw crowds, looting and rioting resulting in injury to protesters and law enforcement, requiring them to access our hospitals for care, and lockdowns ensue, creating isolation and potentially mental health issues. Next. As we think about the future of COVID-19 infections, there are certainly things to consider. We look back in the past, while that is much behind us, there are certain concerns for rural areas as hotspots are beginning to appear there, where they are also seeing per capita rates similar to those in cities and have similar, if not worse, social risk factors. States and services are beginning to reopen, encouraging interactions and potential transmission of the COVID disease. There's increased activity and travel during the summer months, including over our holidays, and large crowd gatherings as people are excited to leave isolation, celebrate, and, of course, protest peacefully in the case of the George Floyd and other killings that have happened across the nation. There are also fears as we enter the fall that COVID-19 will coincide with a flu outbreak. With all that's happened and all that may come, there's a great deal of opportunity to explore our lessons learned. Next. And with that, it is my great honor to introduce our guest speaker, Dr. John Lynch. Dr. John Lynch is an infectious disease physician and an associate professor of medicine at the University of Washington School of Medicine. He's also an associate medical director at Harborview Medical Center, where he leads the infection prevention and control, employee health, and sepsis programs. In addition, he's the clinical lead for UW Medicine's COVID-19 response efforts. Sean's been involved with this response since the middle of January, when the first patient in the U.S. with COVID-19 was diagnosed in Washington State, and has been active locally, regionally, and nationally, including chairing the Infectious Diseases Society of America's COVID-19 PPE guidelines. It's with great pleasure I hand the ball over to Dr. Lynch.
Thank you so much, Jennifer, and thank you to your organization for inviting me today. Can I just get a quick thumbs up that my sound is okay? Great, thank you so much. So that timeline was really helpful, and I'm going to try to reflect back on that as we go through this. The point of, I think, my presentation is to sort of reflect on the things that I may have learned over the last several months, particularly here in Seattle, where we dealt with this epidemic just a little bit earlier for various reasons that I'll describe as we go through this. I have a lot of photos, and I'm going to try to, again, demonstrate or share insights and then try to sum it up at the end, and I look forward to questions as we go forward. So if you can give me the next slide, please. So as Jennifer mentioned, I'm an infectious disease doctor. I run our infection prevention and control program here. I've been doing this type of work for the last 10 plus years. And I'm at Harborview Medical Center. Harborview is a level 1 burn, trauma, and mission-driven hospital, like many of the hospitals on this call. We're about 415 beds, about 98 beds of those ICU. And we have a kind of unusual situation in that we are the only level 1 trauma and burn center for the Pacific Northwest, so we serve a number of states. And you can see in the bottom right there, the helipads, which are pretty busy. We have, because of this part of our mission, it has really been incumbent upon us to make sure that we continue to be accessible for trauma, burn, and our mission population in the surrounding area and neighborhoods throughout this, and that has really been part of our, kind of one of our guiding lights, but has remained a challenge as we go forward. Next, please. Harborview is also part of UW Medicine. We actually, there's 4 hospitals in our system. So you can see top right is Valley Medical Center. That is also a county hospital, but is a community-based hospital about half hour south of us that serves a large part of South King County in North Pierce County. On the bottom left is UW Medical Center. This is a quaternary care center that does a lot of solid organ transplant, cancer care, very advanced surgeries, and so forth. And in the bottom right is Northwest Hospital, which is actually now shared hospital with UW Medical Center on the left. Now it's a campus of that same hospital system, and they're a community hospital in northeast Seattle that serves a larger, older population, including a large skilled nursing facility population. Next. We also are part of, in UW Medicine, part of a large network of neighborhood clinics. So these are primary care and urgent care clinics. We have an airlift service on the top right that serves not only the local area, but the Pacific Northwest with both fixed and rotary wing. And then we also have the School of Medicine. So when we think about how we've responded, or I think about how we responded, I really, all these parts around how do we approach this as a system, how does each hospital support itself and its unique populations of patients who we see, how do we deal with trainees, how do we deal with primary care clinics and urgent care that are spread throughout. Here in my state, we call Western Washington, the western part of the city, of the state, west of the mountains. And even how do we transport patients coming from Alaska, Idaho, and so forth, who may or may not have COVID-19. And so it's been a real complex process as we go forward. So next slide. So this story for us really started, as Jennifer pointed out, in kind of the middle of January. So this is a snapshot from the Seattle Times, where you can see a representative from the CDC and our governor and our Secretary of Health behind him describing the first case of COVID-19 in the United States at this time. This was a person who had traveled from Wuhan, arrived in the United States here in the Seattle area, and felt well at his time of arrival, but soon after developed symptoms, and through his own searching in the internet, was concerned that he might have COVID-19 and was seen a couple of times in urgent care, finally mentioned this to a provider and got tested, and was found to have COVID-19. This obviously engendered a lot of concern because it was completely unexpected this time. He ended up being hospitalized in a hospital just north of Seattle, about 30 minutes, called Everett, Everett Hospital, part of a larger Providence system, and really kind of woke us all up to what was really going to potentially be happening, and started making us think as a system here in my particular hospital, what would it look like for these travel-associated infections. Next, please. Because of the Ebola outbreak in 2014, we had worked with public health around this idea of doing home-based assessments to keep people with potentially dangerous infectious diseases out of hospitals, particularly Harborview Medical Center, which also serves as the sort of de facto quarantine hospital. So if someone showed up from another country on a plane at our local international airport, that if there was some concern that person would be transported to my facility. And these things really, in terms of planning, really began in earnest in 2014 with the Ebola outbreak in West Africa. And we had this idea of a home assessment team, which ended up not working really well, but was still on the books and something we had sort of trained for. It was really developed in large part by the person you see in the middle there, Vanessa McCarowitz, who's a nurse manager and is really my partner in infection prevention control at Harborview. What we basically a few days after that first exposure in Everett, public health contacted us and said, hey, we've had about 60 exposures to this person. We can't do all of these in-person evaluations for people. Would you be willing to stand up this home assessment team to be able to do home-based assessments with a physician and a nurse and do testing for SARS-CoV-2 in these facilities? And that was Saturday morning on the 27th. By Saturday afternoon, we actually stood this up and I think rolled out on Monday for our first test. And this is a snapshot from one of the homes that we visited from someone who had traveled from Wuhan and had symptoms, and public health contacted us to reach out. So we kind of got involved as a hospital very, very early in this whole process. Next. Over the next couple of weeks, just like many hospitals on this call, we started dealing with people showing up in our emergency departments who had traveled and sort of met these criteria per CDC for evaluation. This is sort of our early phase PPE. This is really before we had a lot of guidance coming out. You can see using PAPRs and N95s. This is in our emergency department. At this point, every single person that came in brought in a very large response. The person with the tattooed arm to the right is our head of engineering. This is really an all hands on deck at a one-by-one case situation. But up to this point, fortunately, associated with that travel case that was first here in Seattle, we saw no positive cases until really February. Next slide. So throughout February, our home assessment team continued to work. We kept dealing with the folks in the emergency departments who might have travel-associated exposures. Until the very last week of February, when things got very active for us. So we were called to go out and do a home-based assessment and testing of a person who had returned from Daegu in South Korea. That was a Wednesday. Looked all the world like influenza. I told that patient she had influenza. It looked just like that based on what we knew about COVID-19 at that time. This didn't look like it. I was completely wrong. And that was actually the first travel-associated COVID-19 case diagnosed in our state on that day that we had done through testing at the person's home. And so that, again, now we're realizing that we do have more cases here. And, again, throughout that February, we had been working on just like many hospitals, working on our policies and protocols, meeting basically every day in the afternoon. But at that point, it was pretty much voluntary across our system in terms of participation, and it was really people just adding on to their ongoing work. Things sort of sped up over the course of next weekend. Next, please. That's 2/29, and as kind of Jennifer pointed out in her timeline, this was kind of a big weekend for us. So around this morning, and this is a Saturday, we had learned that there was a patient who was diagnosed out in the community who had never traveled, and public health asked us to go out and retest him to make sure that he was no longer infectious and test his family. The thought at that point was, let's get this done in the morning. We can have the rest of Saturday with our families. But none of us actually got home until about midnight that night. Around the same time, we learned about the diagnosis of two patients at another facility, Evergreen, Hospital here just north Seattle by Dr. Frank Rito and his team there, where we learned about the first cases coming from a skilled nursing facility. And then that afternoon, we learned about one of our hospitals, Valley Medical Center, had an exposure to a COVID-19 patient that had been hospitalized for about a week. And so we sort of spent that evening figuring out how are we going to respond to a large exposure scenario. So a lot happened that weekend, and that really led to the next slide, where we stood up our Emergency Operations Center across UW Medicine. So this is all of our hospitals and those neighborhood clinics and Airlift Northwest. And we also stood up our Emergency Operations Center and Incident Command at Harborview Medical Center. Now, we're used to doing this because we deal with trauma, and we're also the hospital for, natural disasters and so forth. But this felt very different in that we saw no end date. And it ended up being a much different experience than I think many of our sort of trauma-focused emergency operations centers have been in the past. In addition, we didn't have a lot of policies and protocols at this point. We had been developing protocols over the prior month, but this following week was incredibly intense because we had to basically on the fly build a whole new series of policies and protocols, which I'll touch on again in a minute. So that's March 1st when we stood that up. Next slide, please. We were very lucky in that our being part of a large academic center with a very well-regarded referral viral testing lab, the UW Clinical Virology Lab had been working on a SARS-CoV-2 test over the prior 2 months, and on that Sunday they were able to get finally FDA permission to use it. And by that Monday night, so within about a day or so of us standing up the EOC and about 2.5 days from learning about these community cases, we were able to start doing testing in-house. And that evening, that Monday night, we were able to actually start testing all admissions with respiratory symptoms, which again put us in a very favorable spot that unfortunately many hospitals in the country weren't able to do. So that's kind of where we sort of kicked off, but things got pretty hard with the next slide, please. Over the course of this week. What really happened, this is from the Seattle Times again, the second U.S. coronavirus death in King County, in more cases likely. And that's a member of our home assessment team, nurses who are going out from our infection prevention team, was in the front page there from Harborview. What we realized is that we actually had a disaster within a disaster. So we had this EOC, but we also had this, what we learned very quickly was a huge outbreak in a skilled nursing facility. This is the Life Center in Kirkland that I think made the media across the country, where a huge number of people were infected, both staff and residents. Very large number of them were very, very sick, and ended up hitting Evergreen Hospital, that first hospital that had made that diagnosis the week before, and also one of our system hospitals, Northwest Hospital. Those are both hospitals can have a large skilled nurse facility catchment, and a lot of those patients ended up coming to their facilities very sick, and unfortunately, by the time they got there, many of them died very quickly in the following 24 hours. So there was actually an outreach to go to that skilled nursing facility by CDC, Department of Health, Public Health, South King County, but also doctors from Harborview Medical Center to go out to the facility and figure out how to triage people and get them out of the facility and get them distributed across our system, as well as other area hospitals. So that first week became very, very challenging, with the recognition of a community outbreak of COVID-19, concern for transmission that had been going on for weeks that was undetected, as well as this skilled nursing facility outbreak that was quite acute and very large and obviously devastating to the patients and their families. At the same time, we also recognized that we had patients in our hospital, particularly at Harborview. We had learned about that first case the week before on Friday. We went back and actually had a death from that skilled nursing facility 4 or 5 days prior. A patient had come in, an elderly man who came in with sepsis, and his family decided to have him transition to comfort care, and he passed away. We were worried about his sepsis presentation coming from that facility and basically presumed he had COVID-19 and ended up getting a test post-mortem and actually determined that he was actually the first death in Washington State from COVID-19. And obviously then we had to deal with yet more exposures. So just a lot of layers in this first week. Next, please. This is just a picture from, I think, that made a lot of media across the country. The coronavirus outbreak in that facility. You can see 70 of 180 employees. This is in early March, had COVID-19 symptoms, so a huge number of people, and that number increased quite a bit over time, and we started seeing connections between the employees, the healthcare workers there in that facility and other skilled nursing facilities. We are very lucky, and I'd say one of the key insights here is the existence of this thing called the Northwest Healthcare Response Network that is primarily in Western Washington, but is really now functional across Washington State, where it's basically a way for all the hospitals to work together in terms of communication, in terms of disaster response. This has been very effective for us. And we also work very closely with the Department of Health with what's called the Disaster Medical Coordination Center. And the point of this coordination center, which is based at Harborview Medical Center, is that in a setting of a disaster like this skilled nursing facility, there is actually a coordinated response to distribute patients across the area so that no one hospital becomes overwhelmed. And these are key to us because if any one hospital went down, that really would impact all the other facilities. And I know this is not common in most parts of the country, but it is really critical for our success here. Next slide, please. So because of that big exposure, we had to find a way to test employees, and this is our first iteration. Our engineers are amazing here and are used to using and building up these temporary basically facilities. This is a public corridor that we had to shut down. We used one of our meeting rooms to set up easy access testing for exposed healthcare workers with any symptoms. And so we had the ability to set this space up. We did it day, evening, and night shifts so that people could easily come in and get tested and be able to go home. And again, using a facility that kept the testers safe very early on. And again, this is within days of that first diagnosis here in Washington State. You can see the very first week in March. Next slide. This is, again, within that first week, our first intubation of someone who was suspected to have COVID-19 in our ICU. We basically decided to set up an ICU specifically for COVID-19 patients, an acute care floor specifically for COVID-19 patients, and I think this model has been used throughout the country. But figuring out how to use specific PPE for anesthesiologists. This is one of our anesthesia providers, Dr. Mike Suter, who's our chief here, who isn't used to using this, and at night having to do this. You know, it's a lot. You can see using a full shrouded PAPR and this using a glide scope with with the video scope and so forth. He's very skilled in use those things, but in this environment was very new and different than things in the past. And again, having to develop these protocols took a huge amount of time to make sure that everyone was safe as we did them. Next slide. This is just a picture of that ICU as we got things rolling. That's Dr. Mark Werfel, who's one of the ICU attendings, was the first ICU attending to take care of patients in our facility very early on. He was also part of the team that was exposed with that first patient the week before. So a lot was on his shoulders with his residents who were exposed, the nurses, the respiratory therapists, and other colleagues. Next slide. This is a quick snapshot. On the left is our ICU. We ended up taking over our neurosciences ICU because of our trauma population and mission. We have a very large neurotrauma facility and service here, but we had to end up using this space because this is what we used before for our Ebola evaluations. And you can see that generally used one or two of those rooms on the right, but we ended up taking over this entire wing and ultimately ended up taking over all three wings of our neurosciences ICU for COVID-19 care patients. And you can see we put a lot of PPE in place there and systems in place. We used a trained observer platform that I think we continue to use and I think has been very effective, as well as the segregation of patients being evaluated for or diagnosed with COVID-19. The floor on the right is one of our medicine acute care floors. This is called 4 East, and this became our acute care COVID-19 floor. And again, using that dedicated space was highly effective. For a large part of the outbreak here, half of it was for patients without COVID-19. The other half, we were able to flex that back and forth over time. Next slide. Just a snapshot of our team. This is a team down in the ED. Again, folks who had been trained and monitored. And I think people were really engaged. Again, this is the first week with this work, and I think felt very energized by it. Next slide. We recognized that all this work that we had done over the prior week really needed to be shared because we saw what was coming, and we made all of our policies and protocols public within a week. This is on the COVID-19 UW resource site, so pretty much all of our policies and protocols are available to anyone, anywhere in the world, and I think many people have used them, again, because we recognize that the last thing any infection prevention, infectious disease, critical care nurses needed to do is be writing more protocols instead of taking care of patients and taking care of their healthcare workers. So this was something we did right away, and I appreciate my IT colleagues for making it happen. Next slide. Here's a snapshot from our ICU team, and I'll just call out, you can see those socks there. I think Harborview gets credit for, if any of you heard of COVID socks, this really came out of our home assessment team where we didn't want scrubs dragging on the ground out in people's homes who may have had COVID-19. And when we trained people, we trained them not to have their scrubs drag. And the way the nurses end up doing this is they started tucking their scrubs into socks. And I bring this up because it sounds a little funny and silly, but it was actually a thing that all of the nurses really picked up on, and I'll come back to this, as sort of a, like, they're all part of something special. It did keep their scrubs off the ground, and people really started to express their individuality in their socks, into the point where, in the middle of March, you could walk around the hospital, you could see who had their COVID socks on, and you knew that they were in the process of taking care of COVID patients in our ED, acute care, ICU, or anywhere. And this is true for doctors, nurses, respiratory therapists, really everyone engaged in the care of these patients. And there's actually a whole Instagram on this if you're ever looking for something funny and interesting to follow. Next slide. So I'm just going to quick through some of the things that happen in our community. So on 3/11, pretty quickly, the government said any gathering restrictions begin. Next slide. On 3/13, again, just a couple weeks in, schools closed. So the schools in North Seattle closed earlier than Seattle Public Schools on 3/11, and then schools across the state. This was a big deal, and it happened very abruptly for us here at Harborview. I think it was a Wednesday night. We learned that they were closing the next day, and we really struggled with how that was going to impact our healthcare workforce. But we managed to muddle through it. Next slide. On 3/19, again, just a few weeks into this, the governor put out an edict saying no more non-urgent surgeries and procedures, which was really the goal to increase surge capacity. Next slide. On 3/23, Governor Inslee issued the stay-at-home order really across Washington State. This was fairly early. You can see that, we're about 3+ weeks into the outbreak here in Washington State, and I have to give Governor Inslee a ton of credit for getting on board with this very early, being a very effective leader, because I think it really saved us a lot of suffering here in our state, and particularly my county, as a result of everyone staying at home. Next slide. That was followed by the non-essential business closure edict coming from the governor, which just lifted a few weeks ago. Next slide. Just a couple other points on this. So this is Dr. Jihan Budak, who's an HIV specialist who is basically seconded to our team. And on the right is Dr. Nandita Mani. She's an infectious disease fellow who works with our infection prevention and antibiotic stewardship program. I am amazed with how much effort my infectious disease colleagues, all my colleagues, but especially my infectious disease colleagues who decided to jump in all hands on deck. We spent weeks in this room in the early part of this in our incident command figuring out how to take care of patients safely, how to protect healthcare workers, how to do drive-through testing for employees and healthcare workers. Jihan Budak on the left basically developed from the ground up with nursing administration colleagues a drive-through testing program at Harborview, which I'll show you a picture in a minute. And Nandita Mani, again, who's an infectious diseases fellow, basically developed a whole exposure process that has been ongoing and has just been an amazing process for us. And it's just incredibly grateful to the amount of work that was done. But the amount of people time that went into this was astounding. I think this EOC was basically had people in it from 6 in the morning to 1 in the morning pretty much every day working on this for at least the first month. Next slide. This is our first iteration of our drive-through site. Again, this is early March. We had another one up at Northwest Hospital, but recognized that wasn't serving the Harborview community, which is in central Seattle and serves a lot of the South Seattle and South King County population. This is our main entrance. So basically shut down our main entrance to get testing for drive-through. We also shut down the road in front to one-way traffic. And this basically tent setup allowed us to do both drive-through and walk-up testing for our patients who don't have access to cars. Next slide. 316, basically all businesses were closed. Next slide. We are very fortunate at the University of Washington to also have, as part of the UW, the Institute for Health Metrics and Evaluation. I'm not going to go through the data presented on this, but basically they do a lot of forecasting and modeling work, and they were able to provide us very early on with a hospital resource use forecast. Now, this looked much different back in the middle of March. Those lines were much higher in terms of peaks and at a much larger confidence interval. You can see where that dotted vertical line is where we are today, June. Just from when I set up these slides a couple days ago, you can see we're well under the surge capacity needed, but these lines look much more different, but it gave us a good picture of what we might need to do in terms of surge capacity for ICU beds, acute care beds, and ventilators. And so we're very lucky there too. Next slide. We set up an ED triage tent, and the idea here is this is a great opportunity to really use a hierarchy of controls approach by keeping people with respiratory symptoms who are not acutely ill out of our emergency department. So our ED entrance is right behind this tent, but basically we set up a triage where the first triage step was by a nurse in PPE, full PPE, at the far end of this tent who could say, oh, you're walking, you have respiratory symptoms, you're going to go into the tent. And if you're walking and don't have respiratory symptoms or something, or you don't, or you're very sick, you would go directly into the emergency department. And over the course of, the end of March, April, and May, the vast majority of our emergency department COVID-19 diagnoses were made in this tent, which had great big airflow, lots of space, all healthcare providers in eye protection, masks, gowns, and gloves throughout. We were able to set up a small x-ray station there to get chest x-rays if needed, but was very, very effective in keeping people with COVID-19 really out of the confined and shared spaces in our emergency department. Our ED at Harborview is probably like others on this call is not optimal. We don't have single patient rooms. It's a lot of shared spaces, a lot of curtains. Next slide, please. This is just a snapshot from one of our overflow spots for patients who are boarding. Harborview Medical Center often regular times we board between 20 and 70 people looking for beds. And this is one of our overflow areas, which was turned into basically another part of the emergency department. And we put up these large barriers just to protect people from coughs and sneezes and so forth. Generally, that's just a big open area. And we use the similar translucent way to kind of cover up our work areas in the EDs as well. Next slide. We had a lot of support from our environment. This is just a quick snapshot of a bottle of wine that one of our surgeons dropped off for our emergency operations center, and I just like the managing COVID as a balancing act, bringing together varied characteristics into a seamless, unique health system is the challenge. And then from chaos comes balance. Let's hope so. And people were amazingly supportive, both from our community and our colleagues, recognizing the work the incident command and infectious disease teams were doing. Next slide. I mentioned the COVID SOCs. That's Jerome Deo, who's our Chief Nursing Officer on the right, and that's Rick Goss, who's our Chief Medical Officer. We had COVID SOC days, or COVID cuff days, and everyone got long socks, many of which were donated to us to, again, support our frontline healthcare worker teams in the acute care and ICU and emergency departments and clinics. Just the teamwork and appreciation was just overwhelming here. Again, that everyone oriented towards the mission of our hospital was critical. Next slide. We set up Respiratory Plus clinics, so basically took over one of our other clinics for a different purpose and turned it into a place where patients who had COVID-19 who were discharged could be seen in a place where they could enter in through an external entrance, and also for a place for people with comorbidities who had respiratory symptoms. Instead of going to their primary care clinic, they could come to the Respiratory Plus clinic and be seen there in a way that had more space, where the team was very comfortable with using cleaning processes, using PPE. And this was, again, very effective way to provide that post-acute care follow-up. Because we recognized very early that a lot of patients who were discharged with COVID-19 ended up needing to be seen very soon after. And in fact, we had a fairly high readmission rate from this patient population as well. And so this is one of the key tools that was really effective for us too. Next slide. We basically decided to take all of the things we put together and put it into an infection prevention and control bundle. And if you work in infection prevention and control, recognize we really like bundles, and we sort of put this into a framework that really informs how we protect healthcare workers and patients. And you can see there's a whole range of things that we use there. Next slide. We use this to inform basically all of our actions now around keeping people safe, and underneath each one of those is a whole host of actions and tools that we have. Next slide. We also have a healthcare worker safety toolkit, really emphasizing a lot of things around PPE, the physical distancing, staying home if you're sick, getting tested right away, support and wellness, and so forth. Next slide. So we hit our peak inpatient census for our system at 122 people, which was a lot for us. This was the beginning of April. Obviously far less than some of the hospitals on this call may have seen, certainly some regions like New York and Michigan. Here at Harborview, next slide, we peaked at 32 patients. About half of those folks were in ICU. At peak, we had 4 people on ECMO due to COVID-19, which is pretty much our max. So a lot of very sick people who are in ICUs for a very long period of time. And really since the middle of April, we started to drift down and down and down. Next slide. At the beginning of May, sorry, it's a picture of me, but we instituted we basically instituted our universal masking process. We had felt very good about our whole PPE program, but recognized at the beginning of May, as people started rolling back the physical distancing in our community and business started reopening, that the risk and as we reengaged in doing more surgeries that were not urgent, or urgent or not urgent, or elective, that we would need to put extra layers of protection in for healthcare workers. And so we've really been working on this for the last month, and I think it's been very effective and pretty well adopted by folks across our system in our hospital. Next slide. So in the middle of April, that was really in preparation for the rollback and allowance by the governor to do non-urgent surgeries and procedures resume. And I'd say this has worked. Most of the hospitals in our system have started to really ramp up quite a bit. But here at Harborview, again, a county hospital, we're almost right back at capacity. It took us almost like a week or two really to get back up to doing the full-scale elective, non-urgent, trauma, burn, whatever care in our facilities. Next slide. This is just a quick snapshot of where we are. This again comes from IHME. You can see that vertical line. It's a little faint there, but you can see that the line in dark blue is the number of tests. The line in dark yellow is the number of confirmed infections. You can see it's been pretty stable and is slightly trending down in my county. We are currently at about 24 or 25 new cases per 100,000 patients, which in my area is basically the threshold for moving from what we call phase 1 to phase 2. So we'll be seeing what that looks like as, again, we roll back additional physical distancing measures. Next slide. As Jennifer mentioned, what we're really looking at is what's going to happen in rural areas. We have a lot of critical access hospitals in my state. That middle dark blue is King County. That's where Seattle is. And if you go down to the bottom right, that bottom right dark blue is actually where Yakima is, which is has a very large or moderate-sized town or city, but has a lot of meatpacking, has a very large Hispanic community, and right now has the highest per capita infection rate on the West Coast. And so when we think about how this is going to move into rural areas and impact our critical care colleagues, our critical access colleagues, we're definitely on high alert for how this is going to roll out going forward. And next slide. So I also want to echo some things that Jennifer mentioned, and this is something that we recognized very early on, is that this infectious disease, this epidemic, has grossly, disproportionately impacted vulnerable communities. And this is illustrated on this slide coming from Public Health Seattle King County. So on the left side, you see the rate of positive results per 100,000 residents, and the darker the color, the higher the rate. And Seattle is basically that leftmost part of that. And you can see there's a lot of dark in the south part of King County. That part of our county has a lot of people of communities of color and is being hit disproportionately hard. And you can see on the right side is the proportion of people from different ethnic and racial groups. So you can see white, Black, Hispanic, Latino, and I think Asian are the top four. And what's really important here is that the gray bars is percent of King County population, and then the blue bar is the number of cases, the proportion of cases. So the top one is white. About 70% of the population is white, but about 42% of the cases are in that population. Now you move down to the Black and Hispanic Latino population. I think this is most grossly illustrated by the Hispanic Latino, where it's about 18% of the population, but about 33% of the cases. And you can see in the Black community about about 6% of the community are Black Americans, and 11% are the cases. So you see almost a doubling in that community proportionally to the white community. And so this is a really critical issue. These communities are served by county hospitals like mine, and there's a mission population. We're really dedicated to addressing these inequities. But again, kind of linked back to what's going on right now with the police violence and the need for protests due to the deaths of Black men in this country for all the awful reasons this happened. This is similarly as an epidemic preying on those historical and structural inequities. So with that, I'm going to stop. Actually, I have one more slide on lessons learned, but I want to open it up because we only have about 8 minutes to go here. You guys have access to all these slides, and you can look at all of these things, but I think it'd probably be better just to talk about questions, if that's okay, Jennifer. So I think I'm supposed to hand it back over to Vanessa. Is that right?
Yes. Thank you, Dr. Lynch. Now it's time for the Q&A portion of today's webinar. If you have a question, please use the raise your hand function to let me know to unmute your line, and I will announce you. As I mentioned at the start of the call, you also may use the chat function to ask a question. We do have a question here for you already, Dr. Lynch. This question is, how are you preparing differently for a future resurgence or future epidemic?
Yeah, so I think what we're doing, this is a question I think for everyone right now, is one, we're really trying to nail down our PPE policy because that's going to inform our supply chain. So I think supply chain is our biggest concern. Do we have enough swabs going forward? Do we have enough gowns, gloves, masks, eye protection going forward? And additionally, what would it look like should we need to turn that surge capacity back on? This has been a huge question in our state. We were pretty effective with the governor's order to stop non-urgent surgeries and create a large amount of capacity, and we actually never exceeded that capacity. But as again, everyone knows, the economic impact of that is significant. We have a large number of people being furloughed at my facility in an effort to preserve jobs going forward. And so how we mediate all of that going forward is a significant challenge, with the understanding that we don't know what's going to happen, right? I think our hospital really benefited from the community-level physical distancing that was put in place by the governor's orders, but I don't know whether the governor is going to be ready to do that again and shut down the city in a way that was really worked. And so I think for a high-level administrator, you're looking at this saying, hey, we emptied out all these beds and we didn't use them. We're not going to do that again. But that was only in the setting of shutting down the entire city. And so it really depends upon all those pieces. But the short answer is we got to make sure we have enough PPE. We got to make sure we have enough training. We got to make sure we have our policies and protocols ready to go, and we need to be keeping a very close eye on the community rates. The community rates going forward.
Great, thank you, Dr. Lynch. It looks like we have a hand raised here. This is Jan Gorey. I will unmute your line right now, and you can state your question.
If it was possible for physicians in Washington to test at the point of care.
Can you repeat your question? I didn't hear the first word.
Can you repeat that?
Sure. Is it possible for physicians in Washington to test at the point of care?
Yes. So, I think access to testing in clinical settings is good. The question is really the results. So we don't have point-of-care testing. As far as I know, there's very little access to point-of-care testing. There's a few platforms out there. I think the one from Abbott says there's 15-minute turnaround time, but the data in our own lab and in publications indicates it's got a fairly high false negative rate. So if you have an outpatient setting where you can follow up with a more robust test, that might be okay. Right? If it's positive, you know what the answer is. If it's negative and you follow up and they're going home and they can isolate and wait, that might be a reasonable approach. Cepheid has a pretty fast one, but we haven't been able to get access to the cartridges. But that may be because those are being used as the primary tool in other parts of the country. So we actually have great access to testing here in my area because of the UW Clinical Virology Lab. One of the challenges I think many of the hospitals here face is that your access to swabs is linked to a contract with some national testing organizations, and the turnaround time for those organizations is days. And that's, I would argue, is not adequate. People should be able to get a test result back in a day. Right? Because that's the only thing that's going to work for procedure and pre-surgical testing. And I think, honestly, in terms of your burn rate for PPE on the inpatient side is, you can't put people in precautions for days waiting for a test result and burn through all that. We sort of quantified this very early on and named it after my colleague Vanessa, the MAC unit. The faster we could turn around that test, the less PPE we burn. And that's really important because even at the peak, 90+% of the tests we were doing for respiratory symptoms were negative for COVID-19, right? So vast majority of people with symptoms did not have COVID-19, yet we're using PPE for all of them.
Thanks so much.
Great. Thank you, Dr. The next question we have here for you is, how did you mobilize quickly to change structures, creating triage tents, employee testing in the hallway, and other tents and the testing processes?
Yeah, so I would say that probably the first step is that we stood up our incident command at my hospital and then across our system. We have never done the system in incident command, so that was new to us. And, it didn't work perfectly right off the bat, but I think made sense. But Harborview is used to using incident command, and I have to say I give a ton of credit to the nursing, administrative, and physician leadership here, is that from the infection prevention perspective, right, I'm very lucky that the infection prevention program at Harborview is very well regarded and well respected. And when we say something needs to happen, they are behind us because it's about the protection of healthcare workers and patients. And so when we said we need to do this, they just said, go. They cleared the way and they said, make it happen. And we were able to do it. So I'd never needed to negotiate the need for many things. And the ability to kind of use innovative, engineering stuff, putting up plastic sheets and so forth, really based on our past Ebola experience, allowed us to do this really quickly and really effectively. And we also recognized that at a hospital level, this was our job at Harborview as a county hospital, as what people think of as a trauma and burn, but also a scary infectious disease hospital, that we had a job. That we were the place that people are going to point to and need to go with this concern. So we didn't really, and you could argue we didn't have a choice either. It had to happen.
Great. Thank you, Dr. Lynch. It looks like we are short on time, but I'll ask you this final question. This final question is, what facilitated UW's ability to recognize the severity of the disease so early?
I would say that two things. One is we're super lucky here. Our public health, Salakin County, led by Jeff Duchens, the health officer, we are very tightly linked. So I have his text, he has my cell phone. All of the infectious disease docs in our county and in Western Washington, we all know each other, and we communicate regularly. So Jeff Duchin and other folks on the infectious disease and communicable disease part in public health, the health officers from the county north and south and across the state, we communicate all the time, and we're very transparent about what we're doing. Jeff listens to us, we listen to him, we trust each other, and so that ability to coordinate informally all the time, 24 hours a day, has been extremely helpful for us because he floats policies to us, he asks us what was possible, what's our status, and he makes sure that it's the things he puts out there are pragmatic and are aligned as a team with what we're doing. So that's key and critical, is that partnership with community docs and public health. The second thing is testing. We were very lucky that we have an outstanding world-class virology lab here that stood up a test that first weekend. If we hadn't had access to that, we would have been in deep trouble with our PPE burn rate, with how our healthcare workers felt in terms of our response. And so the ability to test broadly very quickly was critical. I can't overstate how important that was.
Great. Thank you, Dr. Lynch. And with that, we conclude today's webinar. Just a reminder, we have a COVID-19 email list for members, so please visit the COVID-19 resource page of our site to sign up. It's a great way to continue the conversation and ask additional questions related to this webinar. Here is contact information for today's presenters in case we couldn't get to your question today. Also, please keep an eye out for an email from us tomorrow that will contain a link to a brief evaluation. Please share your thoughts, which can help us to ensure our webinars best meet your needs. The email also will contain a link to a page with a recording of and materials from today's webcast. Thank you again to our speakers and to our audience. Enjoy the rest of your day. Goodbye.